Hi, I'm here with Alexei and Elle. My name's Elliot Greenman, and today we're going to talk about pain. So, Alexei, talk to us a little bit about pain.
Yeah. I think that's where it becomes quite interesting because we've talked about all the advertising standard agencies, conditions we can advertise, we treat as osteopaths. And I think the commonality about all of that was pain, basically. Back pain, shoulder pain, low back pain, toe pain, whatever pain and thing. But it's really a common thing because everybody talks about it all the time. And actually it deserves a little bit more attention because we need to really differentiate two different type of pain or pains. We got like a very acute pain and we've got very long-standing and persistent pain, which some people call chronic pain, but that's a different story. Acute pain, you sprain your ankle, we've got inflammation, some swelling, some discomfort, or pain, basically, okay? And we're gonna have restriction in mobility, all sorts of other things happening there. 6 weeks down the line, your body does quite a good job and you're not in pain anymore, okay? But in a few cases, people are gonna have a pain that persists. So after having sprained your ankle, if 3 months, 4 months down the line, your ankle is still painful, well, actually it's not really acute pain anymore, and the mechanism is far different, basically, and it's called persistent pain, okay? So the pain persists and carries on, and it's a very different mechanism altogether, and we should almost coin a bit of a different word, but I don't think maybe I've not really found one yet. I'm not too sure if anybody has either.
Coin a different word for persistent pain.
Yeah, and rather than calling it pain, actually,
okay,
we hope to maybe call it differently, because it's actually not at all the same process as pain, as acute pain, okay?
Okay.
So basically, there's no tissue, despite having no tissue damage, you are still in pain, okay? And then that's what we'll talk about in our next video, potentially about like the pain gate system, okay?
So when you talk about acute pain, which is pain that, let's say, doesn't last longer than 6 weeks or 6 months or something.
Who's got traumatic onset, for example.
So
type thing.
Acute pain can still be really, really painful, right? Because acute to me sounds like it's just a little bit of pain or a little injury.
So we talk about acute versus chronic. So we talk about acute being quite sudden in terms of the onset and quite short-lived, basically, okay? We're not talking about intense pain or less intense pain or things like that. We talk about how long it lasts, basically, okay?
So acute and persistent is along one axis, so then intensity is
another one, okay? And that's where we need to talk about the pain gate system in order to have a framework we can kind of understand that a bit more clearly, basically.
Sure. So you've introduced acute pain and persistent pain. And do you want to talk about the two different types and introduce the pain gate
system? Yeah. So I think once we've clarified the fact that acute pain and persistent pain were two different things, we need to understand a little bit the neurological mechanism that we go through in order to modulate pain. So we've got an innate way, and there's things about us and our nervous system and our brain which actually enables us to actually dial up or down pain, okay? So we've got like a peripheral modulation, okay? And we've got a central modulation. So that's two different things. So peripheral modulation is based on embryological layers. So there's 3 layers. We are triploblastics. We are not like diploblastic like jellyfishes type thing, but we are triploblastics. There's ectoderm, mesoderm, and endoderm. Basically, 3 layers. And then one is going to do the ectoderm, is going to do the skin and the central nervous system. The mesoderm is going to do the muscle and the bone, let's say. And then the endoderm is going to do the gut. Okay, or organs, basically, type thing, okay? To simplify it quite grossly.
So skin,
skin, muscles, and gut. Okay. So that's interesting. And so you've seen people like that, when the kids fall, ooh, it was painful, type thing, okay? So you're going to kind of brush the kid's skin. For example, when I do it to you, you're like, whoa, you're a bit back. It's a bit patronizing type thing. But for a kid, you actually, by brushing the skin, you kind of, you hijack a little bit the pain system, a little bit, and you can dial down a little bit the pain, okay? And the perception of pain, okay? And we can do that with muscles, and we can do that with the gut.
But
Okay?
you probably do it a different way than...
A different way, yeah. So we use myofascial work, which is not quite the skin, but the skin is involved as well, and the muscle is involved, but the fascia is involved, the joint is involved. We do a bit of cracking, we do a bit of mobilizing, PNF, MET, all the different techniques we got on our arsenal, and visceral work a little bit. So we can, some people use taping as well, or TENS machine, those kind of things, like who tends to actually help to dial, modulate the perception of pain. Okay, so we got all that to our arsenal, and the way I then to treat people, I work viscerally as well as on the dermatome, the myotome, and then the gut parting. Okay. Here we talk about the fact that the gut and the muscle or the skin tend to share the innervation of their blood supply. And then we go to the flight and fright and the rest and digest system, the autonomic nervous system. And for you to run away from danger, you need to take the pool of blood away from your gut into your muscle in order for them to perform better, okay? And for you to be able to run away, climb the tree, escape the saber-toothed lion, okay? And when you've got the saber-toothed lion on a spike, by the fire, and you're about to digest, you want the blood to go away from your muscle into your gut, okay? And that's mediated by the same nervous system, okay? And that's quite an important thing that we're going to work with, the autonomic nervous system here, okay? So if the blood there's too much blood in one place, there's going to be inflammation, diapedesis, a bit of swelling, all those kind of things, and we want to try to use the muscle to get rid of the inflammation in the gut, or we want to use the gut to decrease the inflammation in the muscle, and vice versa, or a variation on the same thing.
Keeping them in balance and harmony.
To try to keep them in a balance and restore the homeostatic balance, basically. Okay.
Okay.
We can go back onto that at a later stage. We can explore that a bit more in practical terms. Okay. And after we go central modulation. So you've possibly been to the dentist or the doctor, or you've seen the nurse who was going to take some blood. Oh, it's my first time I'm taking blood. It's going to hurt like hell. Maybe I'm going to bruise you. Well, your experience is going to be very different than, oh, don't worry about it. I've done it so many times. You're not going to feel it. Okay? And then people can set you up and actually make you believe that it's going to be painful or not. And that's going to dial up or down your perception of pain. Okay? So we got a belief system about people walking on hot coals. Well, you don't do that first thing in the morning before your double espresso. Okay? You have to prepare yourself. You have to really psych yourself up to be able to do it. Okay? And people do it, therefore it's possible. Okay? And you've got a bit like behavior a little bit. So you got belief and behavior. So let's say you ping your hamstring every time you run. That thing. Oh, I'm gonna have to stop running. Running is really buggering my hamstring, and if I run, I'm pinging my hamstring. I need to stop running. So you're gonna kind of go from running to not running. Okay? So you're gonna change your behavior. When actually running is no problem. Okay? But it's maybe the way you mitigate the effect running has on your hamstring that is not really up to scratch. Okay?
So it's that you need to address rather than the running itself.
Exactly.
Yeah.
Exactly. Okay.
Yeah.
So it becomes quite an interesting way to reframe thing a little bit.
The thought around pain.
The thought around pain. Okay? So we go back to that acute pain where there's tissue damage, okay, and then all the malarkey goes with it, okay, and the management of that is in a certain fashion, and then you got persistent pain, who's gonna have to be managed very differently because there's no tissue damage. But you believe, you behave in certain fashion, and your different tissues are locked in a certain neurological pathway that makes you think it's painful, when actually it's not. Okay?
It's a positive reinforcement of the pain being there.
Positive reinforcement indeed, and then you can dial the whole thing down a little bit, and then by actually reframing the whole thing, it's actually possible.
Talking about persistent pain, and let's say, for example, surely there must be times where there's persistent pain and there is persistent tissue damage. So there must be some injuries that do last for 3 years, or take that long for you to open it up and actually treat it properly.
Yeah. So I think you talk about neuralgodystrophic disorders, which are quite complex pain syndromes, but that's pretty much. Or another one is a phantom limb. So nowadays you're on an IED. In Afghanistan, your leg gets blown off, and then you still got pain in your foot, but you don't have a leg. So that's where it goes as well. So there's no leg, but you still have the pain.
But is that a similar thing to when you're getting persistent pain?
Exactly.
It's very similar.
Very similar mechanism, basically. Okay.
So how do you, as an osteopath, address that? If I come to you with, you've treated me a handful of times for pain, sort of upper shoulder, upper back pains. That they're long-standing pains. I've had those for a long time. So how do you address that with a customer?
But you realize that you've been using your shoulders in a similar fashion for a long time as well. Desk work, you do a bit of computing, all those kind of stuff. You're doing website for people, so you're quite sat quite a lot of the time. And you go and exercise as well. And the way you used to exercise was to actually work on the strong muscles, all those kind of things. So we've tried to change a little bit your behavior and your understanding. You're maybe sitting on a Swiss ball maybe at work now, so your AP balance changes. You do a few stretches. So you've changed a little bit the way you're using some of the muscles on a long-term basis, and therefore posturally things start to change a bit, and your postures tend to adapt, and therefore your perception of pain changes. Okay. After the whole central, that's the peripheral modulation. So we worked on your trapezius, we worked on your pecs, we worked on muscles, we worked on the skin around your neck, we've worked on your lungs a little bit, we've worked on your large intestine, we worked on your diaphragm, we've worked on different structures which are actually not quite in your shoulders, but kind of associated with it.
With making me tight.
Which are actually positively reinforcing the pattern here. And we've had a bit of a mechanistic and using the peripheral modulation, exercises, posture changes, your awareness of it, all those kind of stuff. And we've reinforced that. And you've got far less discomfort in your shoulders all of a sudden, okay? After, yes, we were about to touch a bit on the central modulation, and there's a few other things which we need to talk about a bit later, which are the human givens, another framework to understand things, and we'll talk about that with sleep as well later on.
So although the pain gate is these two sort of columns of pain that you've spoken about. There are other mechanisms that massively impact those that could be at play.
Of course.
And so those kind of need to be addressed so that you could understand why the pain's being persistent.
Your belief system and your behavior is quite important, and that's really the central modulation of it. And we need a framework there to address. So the peripheral modulation is great with the muscle, the skin, the muscle, the gut, and it's quite easy to kind of grasp, and the stretches, all the different things we can do about it really, okay? But then we need to look at another. With that pain gate, we need to look at the central modulation and have a bit of a framework and understand a bit more about what we mean by all that, really. And that's where Joe Griffin has coined that expectation fulfillment theory of dream, and he's a physiologist, and he's really looked into dream and what it means, and that's becoming a complete revolution about how we see pain, for example, and addiction and depression and mental health.
And that's Joe Griffin.
Joe Griffin, excellent work.
Nice.
Sublime work.
What book would you recommend?
Godhead would be...
Godhead by Joe Griffin.
Joe Griffin and Ivan Tyrrell. really, the most influential work I've read about human body, basically.
Wow.